Okay, I know people are still kind of slowly filtering in, but we're going to get started. Good morning, everyone. Thank you so much for joining us for our May CE event in our monthly Child and Adolescent Professional Development Series. This is our final one for the school year. I'm Donna Bartlett. I am a member of the outreach team here at Suncloud Health. Suncloud Health provides integrated, nuanced treatment with residential PHP, IOP, and virtual services for adults and PHP and IOP for adolescents ages 12 to 18, focusing on the treatment of the whole person in Naperville, Northbrook, and Lincoln Park. If you are interested in learning more about our services, Lori and I, our contact information will be included in the last slide for your reference. To make a referral, you can contact one of us directly or call our intake number, which will be listed. Lori and I will be following up with you as well after the webinar. Please note that to receive your CE credits today, you will need to remain on Zoom for the entirety of the presentation. Also, you will receive an email including the quiz and the survey. So please complete these to receive your CE certificate by email. You should expect to receive your CE certificate within about 10 days. Okay, let's get to our presenters. I'm happy to talk about our two presenters who are obviously near and dear to us. They're both with us at Suncloud. Colleen Kestel is a registered dietitian, and she has her MBA with a concentration in healthcare. Colleen has worked in a variety of roles, including diet technician at residential, director of nutrition services for residential PHP and IOP levels of care, and she has been the assistant director of operations and is currently our director of operations and compliance. In 2022, Colleen co-founded a Joint Commission accredited IOP, an outpatient program in Will County, addressing a critical gap in local mental health and eating disorder treatment options. She has led multidisciplinary teams and helped implement evidence-based practices that promoted patient-centered outcomes. Clinically, Colleen has extensive experience working directly with individuals and families across the lifespan, offering support for eating disorders, co-occurring mental health issues, and complex care needs. In her current role, she has led regulatory initiatives, policy development, and program operations, which helps Suncloud ensure the high standards of care, organizational accountability, and sustainable program growth across all treatment settings. We have Alexander Chevalier, our MD. He's a board-certified adult, child, and adolescent psychiatrist who completed his medical training at the University of Wisconsin, followed by adult residency and child-adolescent fellowship at the University of Illinois in Chicago. Dr. Chevalier has worked across the lifespan in both acute inpatient psychiatric facilities, as well as traditional outpatient practice prior to taking on his role as medical director of adolescent programming here at Suncloud. He has treated a wide variety of psychiatric disorders, including mood, anxiety, substance use, and neurodevelopmental disorders, with a particular focus in childhood trauma, substance use disorders, and eating disorders. He is looking forward to a contentious year of football between the Packers and the Bears, and the Packers ending up the superior team for yet another year, which we'll agree to disagree. There you guys go. Thank you so much.
All right. Thanks, Lori. Hey, everyone. Sorry, Donna. Hi, everyone. We are going to get started. Throughout the time, I am more than happy to take questions as we go, so you do not have to wait to the end, and Donna and Lori will help facilitate that. So just quickly, what you guys are expecting from us, we're going to talk about just the prevalence of eating disorders and substance abuse, as well as them combined, and kind of just seeing what the early intervention or the signs you guys can be seeing within the schools and the adolescent population and how you guys could be involved. So I want to start with a brief overview of different types of eating disorders. Some of you may know this and some not, and that's okay. So when we have eating disorders, our three bullet points, the first three bullet points are the most common ones. So we have anorexia, which is a very severe restriction of food intake, leading to a significantly low body weight typically. And this is often based on an intense fear of gaining weight and having a disordered body image. With bulimia nervosa, this is sometimes often seen as a restricting, binging, purging like behavior, where they might be engaging in binging behaviors and then resulting with vomiting or excessive exercise or laxative abuse as their compensatory behavior. Their body weight might fall within the normal range, so it might be harder to detect when they go within those cycles. Next is binge eating disorder. This is where we're having that large quantity of food intake, often to the point of discomfort. However, unlike bulimia, there is no vomiting, excessive exercise, or laxative use. Other specified feeding and eating is kind of um, one that is used when the above three are going on, but they don't necessarily meet the DSM-5 criteria to have that diagnosis. Whenever I'm working with the patients, I tell them I don't necessarily care what the diagnosis is. I want to know what the behaviors are so I can work with them on treating those behaviors. It doesn't have to have that specific level. We're going to do one-on-one care. We're going to work with them. Each patient is a different meal plan, their treatment goals, their treatment interventions can look specific to them. It doesn't have to fit into that box. Unspecified feeding or eating disorder, this might be something that's used during like a quick assessment or an emergency room visit, just while someone is still gaining more data and understanding of what the recent or historical behaviors have been in order to diagnose it. So this is one kind of like used as a placeholder. And then we have RFID, avoidant restrictive food intake disorder. This is something that we have really increased the amount of resources we have available and more research and understanding of what this is, because a lot of people think that it's just very severe picky eating, where it's not. It is an actual disturbance in their mind of certain foods that could be due to sensory, so texture, color, smell. It's a huge or a concern of choking. So it's more of a nutrition deficiency, not the type of anorexia or bulimia where it's body related. Okay. So please put in the chat if you have any questions about those types of eating disorders, but I wanted to introduce them. Next is, kind of like, why is all this important? If one of us misses a meal, my body is resilient that it's going to be able to move forward and handle it. If I overindulge at a kid's birthday party on cupcakes, my body's going to be able to be resilient and move forward. What we're concerned about is when these behaviors have a long history, and then we're going to get into with the substance use, the long history plus the added substance use is putting them at a higher risk. Our young bodies, it's very difficult when I'm working with the teen and kid population because their body is so strong. It takes a lot of that negative impact to finally like catch up to them, so to say. So I'm fine. Why do I have to eat? I always feel fine. I don't feel thirsty. I'm not dehydrated. So not having those consequences because our bodies are so incredible, makes it kind of easier for them to hide these behaviors. Once they start seeing them, then that's where a lot of times where we bring these interventions. But it's, really important to get ahead of it. So it's the seeing the behaviors hopefully is first, but these are some of the medical concerns that you might notice in a teen. A lot of those are, pretty self-explanatory, but the one I really want to focus on is the electrolyte abnormalities. This is something that's really important that all medical providers and dietitians look at when we're getting labs. I don't know that not everyone understands the severe impact of what one's electrolyte imbalance might do on their body. It's, really holds all of our organs and systems together. So it's very common and potentially life-threatening complication of an eating disorder, especially those conditions that do involve the purging, restricting, or severe malnutrition. So any of the ones that we spoke on the last slide could have this as an outcome. So if you're engaging in vomiting behaviors, purging behaviors, we're worried about your potassium. And the potassium is really what helps us going, so it's going to impact the heart. Same with their pH level in their stomach from vomiting and their sodium. If we're vomiting and not drinking water, we're going to have very severe dehydration. Laxative abuse can result in some of the same, low magnesium, which could result in like the muscle cramps, headaches, potentially seizures or cardiac arrhythmias. When we're restricting our intake completely, we're looking at probably low potassium, magnesium, phosphate, which refeeding syndrome is a symptom of that. This isn't something we often see at this level of care. Refeeding syndrome is likely more in an inpatient setting, if they're at risk, maybe if they're on a feeding tube, but it's that very severe, like rapid increase of nourishment when they've had a very severe decrease of nourishment. We just need to ease our body into it. So the goal isn't to get right back to 100% of, intake. We want to reintroduce it to our body so we could keep our normals level. So that's often one of the times, some of those things that we're looking for when we have patients with eating disorders. So some of the common behaviors that this is important for all of you to be aware of what some of these behaviors are of something that you're observing. Like I said, it's not like a one-time thing. It's a common behavior if you see them frequently. So during the school setting, if you notice, one of the kiddos never goes to their lunch or never brings a lunch, it's really important as the intervention to just get curious with them. Maybe they don't have the means to bring a lunch to school. So it's something we want to get the family involved in. Maybe they're, very stressed or have heightened anxiety because the class is before their meal or the tests that they're going to go to after their meal. So creating a safer space and a setting for them to engage and feel comfortable and be able to nourish their body. Because just imagine how we all feel when, we've had a whole work day and if we didn't eat a good lunch, we're, likely sluggish and groggy. Just sitting in a class all day, our brain needs the food. So if you're noticing they're not doing well, maybe it's a student that always did well in the past and all of a sudden they're not, it's something that we want to look into. As far as anorexia-like behaviors, a lot of times we see like underportioning or really small biting of their food, measuring their food, ripping it apart, kind of like making the meal look disordered. Because if they're making it disordered, it's less appealing. Okay. They might be hiding their food, throwing away their food, giving their food to their friends. Or you see it the other way, that it's someone, like constantly waiting for those leftovers from their friends or wanting, asking their friends for some of the food, just always feeling hungry or needing to leave class because they're always hungry. So important about these common behaviors is just being, like I said, just being curious and looking around to see, is this the normal behavior of this kiddo, or is there something we can intervene with? And just having that conversation of, what's going on? How are you feeling about during lunchtime, I notice you're not with any of your friends, or, I notice you're snacking in every class. How are you feeling? What's going on? Without like making them feel guilty or ashamed. So the different levels of care for eating disorder treatment and all mental health treatment, we have outpatient all the way to hospitalization. So outpatient is like a one-on-one meeting with a dietitian or a therapist. So that could be a good place to start. So working with, programs in the area, our lovely team we have, Lori and Donna. But then also, there's a lot of great providers that have outpatient programs with what's important is that you find a dietitian who knows eating disorders. I would not work with a kid who's on a feeding tube because of a complication at birth. That's not my specialty. So same with, we don't want like a health coach or like a weight loss coach treating someone with an eating disorder. So we all have our specialties and it's important that we're looking into that. So setting them up with the right resources. And if that one-on-one's just not enough, we have intensive outpatient, which is our IOP program, partial hospitalization, which is PHP. So IOP is a shortened time where they might be able to do after school, whereas PHP would be more in place of their school. So think of it as like a traditional school day. The next level of care is if someone can't be supported at home or on the weekend to keep them safe and nourished and sober. This is where they would be living, 24/7 for several weeks. And then the goal is always to avoid inpatient hospitalization, where this is someone maybe who has such low body weight or medical complications that they're bedridden. And it's just really important that whenever, one of your students might be at a program that you're staying involved, you are still considered that team. It's not just handing them off and waiting for them to come back. Talking about how can we help them get reintegrated in the school? What are some of the, pressures or concerns of school that we can keep them on track once they've put in all that work in their treatment? to be able to return to the school setting. Because, we want all the kids to follow their own traditional timeline. It's a crucial time of their life. We don't want them to feel punished or different. Okay. So before we move over to substance, like I said, I wanted to give an overview of eating disorders. Is there any questions on eating disorders? I'll just give you guys a second.
And throughout the presentation too, I forgot to say, feel free to put questions in the chat or the Q&A and we'll get to them. But obviously, if there's questions now, feel free to raise your hand or just unmute yourself. Thanks.
And as I just turned to that, I realized my slide with our data of our eating disorder data got misplaced. So I will make sure to pull those numbers in when it's appropriate later on in the presentation.
All right, so I'm going to talk to you all a little bit about substance use in adolescents. I'm trying to give everybody the most up-to-date data. Exciting times. May is the time in which monitoring the future data comes out for the year prior. So we actually have 2024 data kind of hot off the press over the last couple of weeks. Some of the final figures are not present, but I'm going to cover a little bit of that here with you all. Next slide, please. All right, so when we take a look at adolescent substance use, there are a couple of questions that people want to know. Oftentimes, things that we're going to track are how illicit drug use is being divided out. There are a couple different categories that this falls into. There will be all illicit use and then illicit use excluding cannabis. These are, of course, as you can see on the slide, non-alcohol substance use. So this includes things like cocaine, amphetamines, opioids, misusing prescription medications, such as benzodiazepines or amphetamines, as well as huffing, which is unfortunately a relatively increasing occurrence in young children, like in 8th grade and the middle school ages. So we take a look at that data in 2024. In 8th graders, lifetime prevalence is 12% for use of any non-alcohol substance, 18% in 10th grade, and then 26% in 12th grade. And then when you go to exclude cannabis, you'll see that's down to 3.5, 4.5, and 6.5%. So the first numbers are important to look at because they are going to look very similar to the numbers you see on the next screen. And I'm going to explain a little bit about what's going on there. And then again, if you're thinking about substances that are not inclusive of alcohol or cannabis, the numbers, of course, are much lower for lifetime use. So we take a look at cannabis use numbers in the past year. 8th graders, approximately 12%, 18% for 10th graders, and 26.5% for 12th graders. If you recall from 7 seconds ago on the last slide, those numbers are virtually identical. What that data is showing you is that almost 100% of patients who are using not illicit substances are using cannabis as well. So there are virtually no patients for whom there's use of cocaine, opioids, amphetamines, ecstasy, huffing that have not also registered positive for marijuana. Now, there's it's a self-survey data that has been around for far longer than I've been alive. There's, of course, some potential that some kids are mistaken and writing down wrong information. But beyond that, given how stable the data has been, how consistent the methods have been for the past several decades, this really goes to show how fundamental of a role cannabis is playing in adolescent substance use. I don't have data on daily usage for 2024 yet. I wasn't able to pull that up. But in 2021, you can take a look and see daily users of cannabis already in 8th grade at half a percentage point, so 1 in 200, but already up to 3.2% in 10th grade and almost 6% by the time you're talking seniors in high school. And then if you do take a look at who at any point in time in their life for 1 month was using on a daily basis, which is considered 20 or more days out of the past 30 days, you'll see that number is 12% by the time somebody reaches their senior year of high school. So these are individuals who very likely qualify for cannabis use disorders. One of the interesting things that has changed with substance use in adolescents is how big of a role the pandemic played. Numbers have all gone down consistently since the pandemic. We'll talk a little bit more about that. And in contrast, adult substance use data has shown, particularly in young adults, that numbers have gone up. And so we've seen this bifurcation where before it was kind of this steady stream from adolescence into adulthood. Now it's kind of separating out where you see a larger number of adolescents who are not using by the time they reach high school, but still an escalating number of people who then are going on to use during those young adult years. In particular, for cannabis, those numbers have reached all-time highs in young adults for reasons that we're also going to talk about, but largely related to legalization appears to be the big culprit with that. All right, next slide. Right. So in the era of legalization for cannabis, we have seen increased regular use by both parents and particularly young adults, and certainly reports of increased accessibility by teens, even though the data has not shown an increase in use in recent years. A big part of the change with this in adolescence is also how cannabis is being consumed. It is very rare to find adolescents where the principal mode of ingestion is smoking the plant, or bud as it is referred to. Nowadays, the majority of the intake is coming through concentrates, mostly via vaping, but also by edible consumption. You will also see kind of the highest potency usage in things like dabs. There's certainly, when you look at survey data from both adults and adolescents, all-time low in perception around the harm related to marijuana, which is very misplaced, and we're going to cover a little bit about why that is coming up here. And then lastly, there has been a spike in the number of acute issues with marijuana. Again, we're going to talk about why, but increase in ED visits, increase in hospitalizations, and increase in motor vehicle crashes. Next slide. Right, so vaping THC, like I mentioned, has become kind of one of the most widespread way of adolescents consuming this. In the past, we were working to purify marijuana as little as 7 years ago. It was pretty rare for anybody to be able to get marijuana to 100% concentration. Nowadays, the overwhelming majority in addition to the significantly increased quantity of THC that's getting into our bloodstream because of the purity, vaping also increases your lungs' abilities to suck out the substance. And so compared to, say, smoking, vaping is an easier product for your lung to extract the substance from. And so it's kind of a double whammy that relates to the high concentrations that people are getting from cannabis. In addition to getting more of it in individual usage, the other big change is how readily accessible this is throughout the day. So most schools across the country are very much struggling to control usage. So now you have a situation where, for example, 12% of high school seniors could have had at least a month in their life where they were using on a daily basis because they can use at school, many bathrooms, sometimes even in hallways, classrooms, cafeterias. Kids are just hitting carts of THC. The third big change with cannabis consumption for adolescents is how much cheaper the substance is. The price per gram of effective THC has dropped precipitously as a result of all the increased science and technology around concentrates, but also as a result of the agronomists doing heavy work to make the plant matter itself much more concentrated. And I'm going to show you a little bit about what that looks like on the coming slide. Right. So in the past 20 years alone, THC potency has tripled. If you take a look to 1995 and you take a look at that THC percent, actually 96 is probably a little bit more accurate. It was about 4% by weight was concentration of THC. And then if you take a look at what that was in 2018, that got up to 16. This graph badly needs to be updated as a mental note to myself. If you take a look in 2025, it is very hard to find THC that is under 20%. Even if you go in asking for the lowest potency cannabis that they will sell you in a dispensary, it is almost impossible to find it under 20%. And most of the THC concentrations are going to run closer to 25. There are some limits to what the plant can actually produce. People think it's around 28, 30%. You'd have to do extra things to fortify it higher into the plant itself. But suffice to say, they've done a lot of work over the last 25, 30 years, the plant scientists, in getting this number up to about 25% on average. In addition to that blue line of the THC going up, the green line is the CBD line. And CBD, in contrast to THC, is not a cannabinoid that induces intoxication. It doesn't produce a high feeling, and it does not go through the addiction pathway in the brain. It's not activating the dopamine circuitry in your nucleus accumbens. And that has actually been postulated to reduce some of the side effects associated with cannabis. In particular, CBD is thought to prevent some of the pro-psychotic effects that THC has. And if you take a look at that green line, you'll see that CBD numbers have actually decreased in the plant as we have tuned our plants to produce more THC. So again, a story where there are multiple things moving in the wrong direction. Plant matter is getting much more concentrated, and the CBD is unfortunately decreasing in concentration. Interestingly, if you were to drive this graph back 30 years during the Woodstock still got high. They still had bloodshot eyes. They still ate a whole bunch of munchies. They still waved and danced to the music in a way that was very enjoyable to them. And so that is just to show you, this 10, 15x increase in the plant matter in comparison to a substance that was already bioactive back then. All right, I'm going to stop on this slide right now to answer our first question. I appreciate you typing that in. Regina is asking, are kids using substances like Delta 9? And are they causing significant problems since the THC is supposed to be less than 3%? All right, thank you for asking that question. I want to clarify this a little bit. When I'm talking about THC here or cannabis, I am principally referring to Delta 9 THC. That is the main cannabinoid that is responsible for getting individuals high and is kind of like the desired thing that people are thinking about when they're thinking about THC. Delta 8 and Delta 10 might be what you're referring to. Those are close analogs to Delta 9 that are being created particularly to sell in places that have not legalized cannabis. Found that if you take a walk down Key West's main drag, you will find multiple stores that purport to be smoke shops, and what they are selling is all Delta 10 THC because Delta 9 THC is illegal to sell in Florida. However, there was a farm bill that made it such that things like Delta 8 and Delta 10 could be sold, which is also why we're having significant issues with our gas stations selling these products in Illinois. Now, state by state, they're going to fight some of these products. The biggest issues with Delta 8 and Delta 10 is actually that they are worse for you than Delta 9 somehow. Delta 9 is already awfully bad, which we're going to get into in a moment. But Delta 8 and Delta 10 on a per milligram equivalency actually cause more psychotic symptoms in individuals who consume them. They don't have any benefits over what's naturally occurring in the plant and are just done to get around legal loopholes and to sell basically to minors and to people who would not otherwise be able to purchase Delta 9. There are no purported benefits to those substances from any studies that have ever been produced in the history of mankind. So they're definitely a big, big problem. Illinois is doing specific work to crack down on that, but it is a very state-dependent kind of situation to figure out what's happening with the Delta 9 analogs such as Delta 8 and Delta 10. There's also other ones like Delta 13 that exist. These products are less potent per milligram as far as their effects on getting you high, and so it's not a one-to-one analogous thing. So if you know how much 5 milligrams of an edible affects you, you hear a kid talking about having 100 milligrams from edibles. It's possible they're consuming Delta 9, which is awfully scary if they are, as it's a profound amount of intoxicant, but in many cases, the individuals are consuming things like Delta 10 edibles, which have, roughly speaking, it's about a third the potency. So 100 milligrams is still a wild amount of consumption, but is often going to look a little bit different than what it would be if it was a pure Delta 9, right? Okay, so I'm going to go to the next slide now. Thank you very much. Okay, oh, yep. So this is an example of a little bit about what I'm saying in terms of potency. I just think it's helpful to put it into image form. These people who are consuming cannabis now are a new kind of consumer. If you can imagine drinking 33 cappuccinos to get 65 times the amount of caffeine as a single Diet Coke contains, that's what we're talking about when we're talking about how much THC was entering people's bloodstreams in the 1960s when they consumed versus how much THC is entering our youth's bloodstream in the 2020s when they consume. All right, so why does this all matter? For a lot of reasons. So let me explain a few of them to you. The more potent cannabis is, the worse basically all of the side effects are. If you will recall back when cigarette smoking was somehow a reasonably acceptable thing in society, where doctors would promote it and say it was this thing, one of the big canaries in the coal mine that eventually came out and that they had suppressed the data of the tobacco companies for a long, long time was that if you had more tobacco going into your system, the rate of lung cancer and heart problems increased, and it increased in a relatively linear fashion. So we call that a dose dependent response rate. And so anytime you see a product where if you have, one pack of cigarettes a day, that's a 100% increase, two packs of cigarettes a day is a 200% increase, three packs of cigarettes a day, 300% increase, that is establishing causality where you see that more of that substance is causing more of that problem. The numbers aren't exactly that. Those are made up. I know nothing about pulmonology or lung cancer, so I apologize for any pulmonologists in the audience here. Now, when it comes to taking a look at cannabis's effects on mental health, well-being, brain development, all of those things, the same thing has emerged, and I think will continue to emerge from the data. So even as long as 10, actually 13 years ago, we were already seeing that people who were using low potency THC had less increase in negative symptoms versus people who were using high potency THC. If you want to get really concerned, low potency THC back then was under 10%, and high potency THC was considered over 10%. As I previously mentioned, it is virtually impossible to buy cannabis that's under 20% THC now a decade later. And so everything would be well past what high potency looks like on these slides. But as you can see, when you take a look at how depression looks with people who have low potency versus high potency, consuming otherwise the same pattern of cannabis, you always have more of those symptoms getting worse, more depression, more anxiety. Next slide. Right. And this also matters for how likely you are to become addicted to the product. So again, if you take a look at 5% THC and the rate of people going on to have problems with addiction versus 12% THC and the people going on to have problems with addiction, the rates are much, much higher. So this is in the same way in which, somebody who's, drinking, a couple beers a day is going to have a lot less risk of going on to develop alcohol use disorder than somebody who's having 6 beers a day or, drinking a whole bottle of wine or drinking, a third of a bottle of spirit. What's most concerning to me, particularly as a psychiatrist, is the rate of psychotic disorders. And so here again, we see that people who are using low potency THC, which is the second column, if you go to the far right on this white slide, that second column is daily use of under 10% THC, and then that last ultimate column is daily use of greater than 10% THC. And so again, there you're seeing significant differences in the rate of increase in psychotic disorders based on how much potency of THC is consumed. This was a landmark paper when this came out 6 years ago, published in Lancet Psychiatry about this imminent concern because potency has continued to go up since then, but was really in its infancy of hitting the rocket boosters that long ago. All right. I think I got one question coming in.
Dr. Chevalier, one of the questions is, I'm looking at the chat too, not to interrupt you, is can you talk about the higher risk for people with autism? Was one of the questions.
Yeah. So there's not an intrinsic link between having autism and having a substance use disorder. Autism is a risk factor for a number of issues, largely issues with socialization. And people that have high functioning autism in particular will often have this experience of intense loneliness, wanting to make friends with other people, but not being able to make those connections in a way they want. There's this misnomer with autism that people think that everybody with autism is just happy pushing a train set around and playing in the room by themselves all the time. That is absolutely not the case. So the place that I really see ASD intersect with substance use disorders is for kids who are really trying to fit in and they don't have the other social means to be able to do that. Sharing substances with somebody else is this, well, first of all, it's illegal. And second of all, it creates this kind of like renegade, like us versus the world kind of experience. And so I absolutely see kids with like level 1 ASD struggling with substance use where it actually has less of an addiction basis, at least to their initial usage, less of a thing where it's like making them less anxious, although they absolutely can suffer from anxiety and depression just like anybody who's not on the spectrum. And the area that I see it most uniquely represented is for kids who just like that's the only way they get to fit in. That's the only way they feel like they can belong in a social circumstance. And so I see it there. The second part of that question is it relates to anybody with a family history of schizophrenia, and I will expand that to anybody with a family history of schizophrenia or bipolar disorder. Cannabis use is probably the single worst thing an adolescent can do that can fall into that space. And I'm literally comparing that to using cocaine, using that to methamphetamines, using that to opioids, unless they resulted in imminent demise of the individual. It is probably the single most harmful thing that somebody with that kind of genetic background can do because it is so promoting of psychosis and manic episodes. And in particular, when you take a look at prognosis for individuals with schizophrenia, the number one prognostic factor is the age in which the onset begins. This is part of the reason why men have worse courses of outcome with schizophrenia than women do, because they have a significantly earlier age of onset. And that in and of itself explains the gender differences between schizophrenia and between males and females with schizophrenia. And so what it is hypothesized is doing with THC is in addition to probably generating psychosis in people who would not otherwise had psychosis in the first place without high potency THC use, is also accelerating the onset. So even for people who say we're for sure going to go on to develop schizophrenia, if they are using high potency THC when they're younger, and there's certainly risk factors for that because they likely have some changes in their brain already occurring from the schizophrenia that's about to develop, that brings the onset earlier and worsens the long-term illness course in a way that's very grave and awful to see. Thank you for your question. Next slide, please. All right, so just talking a little bit about what cannabis looks like on the developing adolescent brain. We had a pretty amazing large study in Canada in 2018 in which they were able to track 4,000 seventh graders. Canada has a unified healthcare system, and this allows them to get really impressive data on large cohorts of individuals that are very difficult to ascertain in the US, except in rare circumstances like with Kaiser Permanente, for anybody familiar with them. And so we get this big population data study, which is really what you need to take a look at kids previous to substance use and then with the onset of substance use and what happens, right? So we tracked alcohol use and frequency, so the amount of alcohol, how frequently they drink, and then THC frequency. Unfortunately, we were not able to capture potency. This is, a 7-year-old sample, a little bit harder to identify some of those things. It's very easy to ascertain 1 beer versus 6 beers. Very hard to say, is 1 gram of cannabis, 5%, 10%, 20% without sending it to a lab and having testing. So pretty obvious reasons why they weren't able to do that. But despite that mild limitation in the study, there are some really big takeaways. Right? So when you're using either of these substances, alcohol or cannabis, in early adolescence, not surprisingly, you have things like lower working memory, lower inhibitory control, lower perceptual reasoning, and poor academic functioning. I think everybody's aware of what the intoxication effects of alcohol and cannabis look like. They worsen all of those areas. They lead to kids accordingly doing worse in school with lower memory, lower perceptual reasoning if you're doing anything that requires, geometric manipulation in your head. So not a surprise for anything found there that kids using those substances did worse in school. But the really interesting part about this study is that cannabis, but not alcohol, caused reductions in delayed memory recall and perceptual reasoning. And in other studies before and other studies after, we have seen that this causes a lasting neurotoxic effect on the developing brain. For those of you who are not familiar with how the brain develops, adult brain functioning takes place largely between the ages of 12 and 23 for people assigned female at birth, and 12 to say 27 for those that are assigned male at birth. And that difference over that time span takes you from a kid who's young and happy and thinking about unicorns and princesses like my daughter does, and somebody who's able to talk to you and have a conversation about the pros and cons and think about the future and judge how much autonomy versus non-malfeasance should be playing in the same circumstances with each other, right? All those moral developments, the ability to project things into the future, our ability to say no to things and delay gratification now to have future gratification later, all of those things occur in your brain, and they occur during that critical developmental window of 12 to early 20s or late 20s, depending on the gender. Cannabis in particular has a unique ability to block the brain from having some of that development take place in a way that other substances do not. So alcohol does not, cocaine does not, heroin does not, fentanyl does not, psilocybin does not, and on as the wheel spins. And so this is a very unique ability of cannabis to impact how neuroplasticity works in your brain. And this is what has also been found in other samples where you see people who consistently use cannabis during this acute window of brain development have lower IQ than their pre-morbid usage or compared to matched controls. There's some amazing studies out of Australia about 7 or 8 years ago that also show that as well. Next page, please. Oh, sorry, we have maybe some questions. Give me 1 second.
Here, I can read them to you, doctor.
No, I've got it. What is the
Okay.
risk for psychosis for those who already have diagnoses of bipolar? Yeah, good question. So in bipolar disorder, the majority of people, that is greater than 50% of them, will be psychotic when they are having active manic episodes. They also have higher rates of depressive episodes with psychosis, although people with unipolar depression absolutely get major depressive episodes that contain psychosis. What I just wanted to point out there is that there's a shared genetic vulnerability between those who have schizophrenia or bipolar in their bloodlines. And in either instance, manic and psychotic symptoms are provoked, particularly by high potency THC. But certainly if somebody already has a diagnosis of bipolar and is using cannabis, it is also going to make them more likely to have psychosis during the episodes in which they're manic, and it is also going to make them more likely to have manic episodes, although also depressive episodes, which is part of the real harrowing effect of cannabis use for people with bipolar disorder. Somebody else asked about vasovagal responses following delta 8 or delta 10. Vasovagal responses are actually underreported, but I wouldn't say common. They're not rare, but they're not common, if that makes sense. They absolutely do happen, and it is not limited to delta 8 or delta 10. Delta 9 THC 100% can cause significant vasovagal responses. I took care of a young adult who was sitting in, a stair hallway or whatever with his vape cart, stood up and then smashed his head into the concrete and got a very significant head lesion and concussion and traumatic brain injury. As a result. That is not like an unexpected thing. That is absolutely as a result of the cannabis ingestion. I don't know of any data that would compare a vasovagal response rate from delta 8, delta 9, and delta 10 THC. That would be an incredibly niche area to study, and I can't imagine it ever will. But I can't imagine there's necessarily a huge difference in. If there were, they're all going to happen with those, and it's bad all the way around. So definitely a real side effect from cannabis. Definitely underappreciated. Excellent that you are aware of that and picked up on it. It is not related to anxiety. It's a direct effect of the intoxicant on the body. For the sake of time, I skipped how cannabis affects the human body, but suffice to say that there are receptors throughout all of your body, your liver, your pancreas, your arteries, your heart. All of these organ systems all have cannabinoid receptors. We are not very well versed in how they affect them, but one of the ways that it does show up is in these relatively uncommon but not rare instances of vasovagal syncope. That's a great question. Right, somebody asked, and we're not otherwise going to get to this, so I'll take this now. What are some recommended interventions or crisis plans for students if they experience psychotic episodes in the school setting? Good question. So the nice thing about psychosis in this case is that it is a true medical emergency, particularly in somebody who's not been psychotic before. This is a slam dunk, 100% of the time, have to get to the emergency, do not pass go under any other circumstances kind of situation. And so it really just boils down to two things. One is keeping that person in a safe, contained environment where they're not hurting themselves, hurting anybody else. The person that you have who has the most calming, slowest, deepest maybe, or just overall calming voice, who can talk softly and appear very non-judgmental and not display much affect, is going to be the right person to talk to that person or whoever's dealt with these kind of situations in the past. But this is absolutely something where it's like a 911 call kind of situation, and so you're really just trying to buy some time. If you can get them into a nurse's office, a counselor's office, someplace where the lights can be not off but dimmer, and just keeping them away from loud noises, lots of displayed emotions. What you don't want people to do is to freak out. High displayed emotion is very consistently associated with exacerbating psychosis. And so just making sure that ahead of time, whoever is going to be having this intervention to deal with a mental health crisis at school has some preparation. It's hard to prepare for psychosis if you've not been around psychosis. I will say even people who spend a lot of time in the mental health space, if they're not psychiatrists, don't spend oftentimes a lot of time with people who are psychotic. So you can do the best you can. You can listen to some psychiatrists talk about psychosis, Could talk to you for 5 hours about that. And look up some stuff online, just try to mentally prepare yourself. But it's really just about quarantining somebody until we can get them there. And then certainly letting the EMS staff know before they have that interaction, like, hey, this person's having, a psychotic episode. This is a new thing to them. We just want to make sure that we can as safely get them to the emergency room as possible. There's a whole host of metabolic workup, oftentimes brain imaging that goes into that, potentially seeing a neurologist, seeing a psychiatrist, a lot of different medical things that will happen following that. Now, 95% of the time in adolescents these days, it's because they greened out, or had other substance ingestion. That's for sure, the top thing on our differential diagnosis. But there are, of course, other reasons for people to have psychotic episodes in adolescence that are not just related to substance ingestion. And those are all worked out in the hospital. So yeah, and somebody said, I think knowing that hospitals can handle psychosis too. Yeah, absolutely. I mean, any hospital that has a children's hospital attached to it, from a pediatric perspective, is going to deal with this not irregularly, particularly even if you're just dealing with unusual medical complications. Many times those adolescents and kids will end up developing psychotic symptoms as a result of their significant medical illnesses. So anybody who's got pediatricians who are used to this, academic centers are going to see this a lot more, than non-academic centers are. But Advocate Lutheran, Lurie's is excellent. University of Chicago, even though they don't have a psychiatric unit as part of their children's hospital, they see a lot of extremely medically ill, kids, and so they'll have no problem dealing with these kind of situations either. And this is absolutely something that child and adolescent psychiatrists and pediatric neurologists, we deal with it all the time. It's not a big deal for us to deal with it. It's a very big deal for the people experiencing it, just to clarify. All right, thanks for all the questions. All right, next slide, please. All right, so just to summarize again, because we're light on time here, adolescent cannabis use absolutely causes issues with academics, occupational performance, cognitive performance, psychiatric performance, worsening depression and anxiety, unfortunately also self-harm and suicidality, which I'm going to cover on the next slide. And then it also leads to worse other substance use outcomes. And so if you think about this kind of like gateway drug phenomenon, ironically, when I was in school, there was this DARE campaign. It turns out that the data behind DARE is complete rubbish. It was not an effective campaign at all, but they did talk about this being a gateway drug, and everybody laughed about it at the time. Interestingly enough, cannabis absolutely is a gateway drug, and if you take a look at that data that I presented earlier, almost 100% of people who use substances like opioids, cocaine, amphetamines, those kind of things, almost 100% of them have used cannabis beforehand. So real concerns from there. The interesting thing that I just want to briefly point out here is that adult onset cannabis users have fewer side effects. That says may, but it absolutely is a yes. Nobody in this space ever wants to promote anything, and so we always step around our words, but it is undoubtedly the case that somebody who's 35 years old and using cannabis for the first time has dramatically less negative effects than somebody who's 15 years old using cannabis for the first time. And the same would actually even be true for somebody who's, say, 25 years old compared to 15. And so one of the big takeaways from cannabis is being able to find a way to delay onset of use. It doesn't have to be a you can never do this the rest of your life kind of thing, but the longer you go before you ever use it, the outcomes are dramatically better. In fact, an old study in adolescent alcohol use was showing that if you took kids that had no exposure of alcohol until they're 21 years old, they have an over 90% reduction in the likelihood that they go on to develop an alcohol use disorder compared to kids who consumed under the age of 18. And so this is one of the few places, again, where I think American policy really gets it right. The policy in Europe that we always look to as being these beacons of things in science and democracy, with the 18-year-old drinking age, it is not better. Drinking with your kids does not improve outcomes. It makes them worse. So in all these cases, when you're talking about substance use, it is very clear that the longer you go before you're exposed to substances, the less harms you have. But in particular, cannabis is the poster child for that. It makes by far the biggest difference in outcome. Because if we're being honest, cocaine at 25, heroin at 25, methamphetamine at 25, real bad. In contrast, cannabis at 25, much less bad than cannabis at 15. Next slide, please. All right, so one of the biggest studies that have come out taking a look at mortality concerns was published in JAMA Pediatrics. This showed that amongst youth with mood disorders, cannabis use disorder was a separate comorbidity and a risk marker for self-harm, all-cause mortality, death by unintentional overdose, and even homicide. So in particular, the death by intentional overdose, to clarify, nobody overdoses on cannabis itself. I don't think it's ever happened. Maybe it has. Certainly people have been so intoxicated that they've died, but not as a result of the substance itself killing them. It's like, falling off of a building, that kind of thing. The death by unintentional overdose that it's referring to is because increased cannabis use leads to things such as increased opioid use, and that's where the mortality often comes. But also it increases directly suicide. And so problems of self-harm, problems of suicide, problems with other substances, and problems with homicide all linked strongly to cannabis use in adolescence. Next slide, please. Right. So just real quickly to give you some updated data on alcohol, eighth graders have used alcohol once, at least one or more times in the last year at 13%, 26% for 10th graders, and 42% for 12th graders. Believe it or not, that has actually fallen from a high, I believe, around the time I was born, about 74% for 12th graders. So we have done a really nice job on alcohol education. If you listen to any podcast talking about anything related to young adults in the generation before me, people in their 20s and maybe early 30s, you will hear constant comments about how they drink less alcohol. You're going to hear stories about how much trouble Kentucky, Napa Valley is in. All of those things are absolutely true, empirically supported. Alcohol use has absolutely fallen amongst individuals who are born in the generation after mine, not in my generation, but after mine in a very significant way. The percentage of daily drinkers, the percentage of people who drink at all of those things are absolutely falling in an impressive way. Now, it's still a significant issue. In 2019, it was estimated that almost 500,000 youth had an alcohol use disorder. Still a huge issue to see, 1% of high school seniors drinking on a daily basis. That's a very significant and severe alcohol use disorder if you're doing that at the age of 18. So a big deal still. We absolutely see lots of harm associated with alcohol, but this has for sure come down in comparison to time in the past, and a real source of positivity for all the work that people have done regarding alcohol education. And I just wanted to wrap up this final point about how COVID has impacted adolescent substance use. We are seeing the kids now taking this data who had COVID around the time they were finishing middle school, beginning high school. That's the cohort whose data is being represented in 2024 for the 12th graders. And we saw this divergence where kids were using less substances during COVID because they weren't with other teenagers. And in contrast to adults who often use substances alone, or in cases of people, small numbers of people, adolescents are often using in these large social gatherings, parties, I think they call them. And so this is a situation in which, because those weren't happening, you have a whole group of people who had less exposure when their brains are most vulnerable, and then have gone on to not use the substance going forward. So this is a rare instance in which COVID had some demonstrable benefits from a substance use standpoint in adolescence. It's going to be very interesting to see how that shakes out over the next 5 years once we get through that kind of COVID cohort. All right, next slide. All right, so very briefly, warning signs for substance use that you might see in pre-adolescence and adolescence: withdrawal from previous activities, money being spent, particularly without seeing any visible goods being purchased. If $1,000 goes off the checking account and a computer or a guitar shows up, that's certainly one thing. If $1,000 goes off the checking account and nothing shows up, that's a big problem. Theft is very common amongst adolescents with substance use disorders, to the point that if you see anybody with significant stealing behaviors, this should be at the very top of the list of things you're concerned about. Of course, there are still conditions like kleptomania. Some kids literally lack resources in our country. Unfortunately, lots of kids do, and are stealing to survive. But substance use would be at the very top of my list that I'd be considering if I saw significant adolescent theft. Big changes in friend groups, particularly to those known to use substances, is probably the biggest red flag. Decline in grades, performance, tasks around home, rapid mood changing, where you don't know kind of who you're going to get one day or the next. Now, every adolescent has mood changes, and you're not always going to know who you get one day to the next, but the way that it presents itself in substance use cases is going to be more extreme than what somebody has presented with in the past. And it, of course, relies on you having a baseline and understanding where an adolescent would be at. Times that people are starting to appear drifted off, distracted, not present because they're not sleeping well, because they're thinking about how they're going to get high next, all those kind of things. And then certainly anything that you're seeing on social media, texts, videos that are promoting substance use, that have pro substance use messages. There's a lot of pro cannabis messages out there. There is so much money that the cannabis industry is pouring into social media, into AI, into ads. And so, those kind of signs are big concerns. Okay. Next slide, please. Very briefly here to just talk a little bit about addiction. Addiction is a primary chronic disease of the brain. Reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biologic, psychological, social, and spiritual manifestations. And so when we think about addiction from this kind of broader standpoint, we're able to think about things other than just substances. We're able to think about shopping addiction, sex and love addictions, addiction to video games, to social media, and all those types of addictions are on the rise. So as we're starting to see some of the substance use go down, what we are seeing replace them are these other types of addictions that we call process addictions taking their place. And so this is a really important thing to understand from an addiction perspective, that we're talking about more than just substances these days. I should have mentioned food as well, since we're also talking about eating disorders. So a whole host of different ways that addiction can show up and manifest in people's lives. You can see some of those other things that are characteristic to all addictions, including the inability to consistently abstain, the cravings, the impairment in behavioral control, dysfunctional emotion responses, and diminished recognition of the problems that those behaviors are causing in their life. Next slide. I am going to very, very briefly touch on what we think of when we're talking about pre-addiction, because it's in the objectives, right? Pre-addiction is a state in which early exposure to substances or high dopamine releasing activities in the nucleus accumbens sets your brain up to look for that type of reward in the future. It's a little bit like priming the pump before you turn on a combustion engine, in which these early interactions cause the brain to then have this recognition and memory of it when it is further exposed to things that cause that effect in the future. And so you start to see this in people where, they used a little bit when they were in middle school, then they use a lot more in high school. I see that all the time for the patients that I take care of. You'll also see this in people who use a little bit in high school, but then go on to use a lot more when they're in college or post high school. And again, going back to that same thing about if you can stop that first initial usage and delay that to later in life, you have less of these priming effects and pre-addiction effects taking place. There's a broader discussion to that, but for the sake of time, I'm going to move on.
All right. Thank you. So I just want to touch on what, bringing these both together, eating disorder and addiction co-occurring. So at Suncloud, we understand that this is a huge piece that we need to be looking at from the start, not treating these disorders or diseases in a separate stance. So the data that I wanted to share with you guys earlier, in 2024 at Suncloud, our average adolescent population had 88% of them had 3 or more diagnoses. Okay. 35 of them had a substance diagnosis. 39 of them had an eating disorder diagnosis, and 10% of those had both. So it is out there. It is something that's very important, and it's very specific to Suncloud being able to treat those co-occurring. So just some of the quick data in these last couple of minutes, that up to 50% of individuals with eating disorders also have that addiction, compared to 9% of the population, the general population. So 35% of people with addiction involving alcohol or drugs have eating disorders compared to 3% of the general population. A lot of times, some people might come to us not realizing this. So I've done so well, I've been able to remain sober, but I'm still having all these other, behaviors or relapses or concerns. It's because the other half wasn't treated. So also vice versa. I'm able to eat my meal plan, but I'm engaging in substances, and it's resorting me back to other behaviors. And it's where we see like the trauma and the anxiety and all the other behaviors with that might be coming through. So I just want to talk about really quick mortality of this. So substances have an additive effect on mortality with eating disorders, which makes sense. So the prevention and treatment of substance is really imperative to reduce that mortality. So we have our hazard rate of certain diseases of what they likely are to result in that risk of mortality. So compared with controlled participants without substance use disorder, the hazard rate for mortality were higher with patients with eating disorder and substance co-occurring. So alcohol is 11, cannabis is 4.55, hard drugs is 14, alcohol and hard drugs is close to 20, and all 3 substance categories is 22. So the goal would be less than 1 when we're talking about this HR. So this is just an idea of what that looks like, of how severe, this is and the increased risk someone is at, that they might just be engaging, they have an eating disorder, that they're really struggling to maintain their, body's neutral state and homeostasis. But then when we add these substances, even with just friends once or twice on the weekend, we might have those cases that we previously were talking about. So risk profiles differed by eating disorder subtype compared to control subjects. So anorexia and hard drugs, 20-fold increase of death, whereas unspecified eating disorder and hard drugs had a hazard rate of 15. And all-cause mortality was not elevated in bulimia alone, but bulimia combined with alcohol or cannabis use was 5, whereas hard drug was 11. Another thing that we could just get into on a whole separate subject is specifically restricting caloric intake throughout the day and then consuming alcohol in the evening to have that quicker effect on, how they feel or what they want, to get that goal quicker. We see it a lot in college kids that don't have the finances to choose food and alcohol. So this is a quicker way to get that end result that they're looking for. If you see this, very close. Eating disorders and substance use are shared risk factors, biological, social, and psychological. So just, knowing what a teen is going through those development years and the added stress. But then when we're looking at these complications, how closely they are related, which is good from a treatment standpoint, because here at Suncloud, we treat all diseases. We look at the main goals of what it is, similar to like what I said. We don't necessarily need that diagnosis label and we put them in a box of what that label is. We know what the behaviors are, which one is primary, which one's secondary, and how we're going to treat both of them co-occurring instead of separating those out. So I just want to give Lori a second to talk about our EDAC facility. It is for our adult population, but it still is really unique and important for you guys to hear. So Lori?
Yes, and because we treat ages 18 and up, this could be an appropriate level of care for a high school senior if they're assessed by Dr. Chevalier and it's deemed appropriate for that unit. But our EDAC unit is a specialized treatment program to address those that are suffering symptoms and behaviors from eating disorder and substance use disorder together. And so it's very specialized, it's very integrated. It is 21 beds. We have 2 separate RTC programs. So this is a specific small program, and we're equipped to treat all of the diagnoses together. So if you have a high school senior that you feel would need a higher level of care, please still reach out to us so that we can assess. And then, of course, we have our PHP and IOP for adolescents that they might be appropriate for if they're safe to live at home. Did I leave anything out?
No, I was just going to say what's also unique to Suncloud is at that facility, it doesn't have to be a substance addiction.
Right.
It could be
Right.
eating disorder and a gambling addiction. It could be an eating disorder and a gaming addiction. So those are some other things that you guys might see in your kiddo population. That is important that we have a really strong team that works on these cases. So I'm just going to leave this slide up. So it's really important to get Lori and Donna's contact information. I'm able to stay on if anyone has a couple more questions. I'm not sure if there's any in the chat or how
Yeah.
we're doing.
I've got a couple more to get to real quick, and then we'll certainly
Perfect.
take anything else that comes up. So a really important question was brought up by Deidre. I also love that name as an aside, so good on you for having your parents choose well. Are the side effects psychosis and cognitive decline permanent? So for cannabis in comparison to the other substances, yes, there's evidence that there are permanent changes in both the rates of psychotic disorders amongst people who use and in overall intellectual functioning in multiple different cognitive domains. Though some of those effects can be attenuated with abstinence, but they don't get back to baseline. They get better than where it was. So it's always a messaging basis where you have to say, like, certainly things can get better than they have been, but they are not necessarily going to get back to where they were. It's a very hard conversation to have, particularly as a physician with parents and patients, because nobody likes to hear that. But I think it's also really important to describe what is actually existent in the scientific literature. And at this point, there have been several studies across different countries and across different significantly different cohorts of adolescents and young adults where that has shown to be the case. In fact, as little as 10 years ago, it was still controversial. Did cannabis only speed up the rate at which somebody develops schizophrenia, which was already really bad for all the reasons I already discussed about how earlier onset is worse, or did it actually cause people to have schizophrenia that weren't going to otherwise have schizophrenia? And the data was not really supportive one way or the other. And even the top addictionologists in the country would kind of tell you, look, it's really bad that it comes on earlier, but we don't know, does it make it worse? Now, flash forward to 2025, it is overwhelmingly clear this is increasing the rate of chronic psychotic illnesses when you have these early onsets of high potency THC use. And so we know this is actually causing people to have illnesses like schizophrenia that would not otherwise have gone on to have that were it not for that exposure to the substance. So yes, both of those things can be permanent, the psychosis and cognitive decline. It's a great question. And then back to somebody, we're bouncing back to anonymous here. I work with a student with a diagnosis of psychosis who sees a therapist and a psychiatrist, but consistently uses cannabis. Any advice on how to best support this student? So great question. You're going to hear some different answers to that depending on who you ask. And so I think it's good to get a variety of perspectives. My perspective is that I would not be working with that patient in an outpatient setting. If they are using cannabis on a regular basis as still a young person and are already struggling with psychosis. I think that is a absolute must be in higher level of care or we're not continue on in treatment with you. There are different doctors and different schools of thought. People will talk to you about harm reduction and that everybody deserves to be able to see somebody and you should never fire a patient no matter what they're doing. There are definitely people who make comments like that. They're reasonable comments. I think it's a place where reasonable people can disagree. Amongst all the child and adolescent psychiatrists that I know who do outpatient work, which is a significant number, and address these on partial inpatient kind of settings, this is like a slam dunk, has to be in a higher level of care. Now, having said that, many of these individuals are going to fall into cases where they do not have private insurance and may not be able to access those services, which makes this situation much harder. In that case, you obviously do continue supporting them the best you can with what you have available in front of you. A big part of that is related to psychoeducation, particularly with the family, making sure they know that this is taking nitroglycerin and pouring it onto a raging fire, and that the final result of this is a place that nobody wants to be. You can go to Skid Row, you can go hang out under the bridges in Chicago. You can see what it looks like for people that are going to struggle in that kind of way, and it is a really, really, really unpleasant way to live. So it's just making sure that people actually are armed with the education, doing anything you can to support them in abstaining from the cannabis, making sure you're aggressively treating any co-occurring illnesses like anxiety, for example, that might drive somebody to use cannabis, making sure the family is able to best support these individuals to make different decisions. I have met plenty of families who have their kids on Medicaid and work in two jobs, but still find a way to lock up anything that's at home, to have as many people involved looking over their kids and making sure that they're not getting into that. But it's a tough order. I mean, there's cannabis on every single street in Chicago. It's a very hard ask, but it's a big, big problem. And so, in medicine, if you have something that's life-threatening, which in my mind, this is a life-threatening situation, you bring as big of guns, so to speak, as you can. And that's everybody and anyone in the community, anybody in the healthcare system, anybody who can do anything to kind of help out in that situation. But a very tough spot for sure. All right, let's see. How early would you start the conversation about avoiding THC for a client with a family history of psychosis? Yeah, great question. The answer to that is clearly earlier than we think. And as a dad, it is going to be extremely awkward in a handful of years. Not that I have a family history of psychosis, in case anybody was wondering, but it's still going to be a tricky conversation. If you take a look at the data and what is happening for our eighth graders, we are already getting a lot of use in middle school. So I really think this is something, end of elementary school, beginning of middle school, roughly age 12. If I had to pick a point that I'd already be making sure to have on a regular basis, I think a lot of people would argue even a year or two before that makes a lot of sense. And I'm probably going to get to that point myself. myself when my daughter gets to that age. But this is not something that you're going to start too early. It's such a ubiquitous product these days, particularly in Illinois around our kids. I have met many a patient who started their use in sixth, seventh grade. Oftentimes, the parents don't know during that time, which is astonishing to me, but I'm sure can happen for very good reasons. And it makes a huge difference. I mean, those kids go on to do really not well. I really don't think you can get to this conversation too early for any kid, but particularly when the deck is stacked against you from a genetic standpoint, it is even more critical in nature to make sure, finding ways to do that are developmentally appropriate and not just barking at the moon, but really hopefully resonating and ideally through multiple sources. So as a parent, you will always know that your kids listen to other people more than they listen to you once they hit a certain age. So any way you can find, to have that good aunt or uncle, that's in Indian culture, what we call all of our friends who are age as us. So, anybody who you can have be around your kid and be a positive influence, talk about any push for legislation to limit the potency of THC. There has. Same thing with nicotine. Look at what Juul did in the US. Our average pod was about 3 times more nicotine than was allowed in Europe. Not surprisingly, that led to a rapid adoption and rapid addiction of the kids who are using Juul pods. As it turns out, that our senators and congressmen are actually very cheap to buy. But not so cheap that the medical societies have enough money to win the war. There's usually approximately $100 of lobbying from the tobacco or cannabis industry for every $1 opposing them from nonprofit organizations and healthcare organizations. It's literally 100-to-1 fight. And so not surprisingly, we lose to money all the time. I'm happy to talk about this to anybody who will have me and listen because it's the best I can do to get the message out and help out and try to reach as many people as possible. But to be honest with you, I would not expect anything to be coming out to limit things going forward. Again, we're at 100% potency and we've nearly reached the max in plants. If you take a look at alcohol, for example, you can go buy 151, you can go buy Everclear on the shelves. We've completely lost any control over that. We did get changes with Four Loko, which was a rare legislative win where they were forced to strip out very high caffeine mixtures with very high alcohol quantities that were resulting in people dying. So there have been some scant wins. We might be able to get something around the edges, but by and large, this is not something that I think is going to ever get solved legislatively in this company. There is so much money being made. In fact, one of the most powerful arguments I have with adolescents is like, do you want to be Philip Morris's slave for the rest of your life? Because they control your cannabis production. And, it's no different than people 60 years ago who are getting addicted to cigarettes and being there to pump up, big tobacco. It's the same players in this that have just moved from tobacco into cannabis. There's a few, separate groups that are owned by private equity firms. Okay, cool. Like you want to be in their pocket the rest of your life. A lot of young kids these days are not thrilled with the over monopolization and increased consolidation and corporate power in America. So they and I have a lot in common, and we get to talk about that and talk about how we don't want to spend our whole lives just funneling all of our excess money. I think that's all the questions that I'm seeing. If anybody has one that I did not get to, feel free to type it into either the Q&A or the chat. But thank you all for your active participation. It's always wonderful to see so many people out in our community who are living this day to day, interacting with our youth. It's facing is the worst it's ever been. Highest suicide rates we've ever known as a nation, highest rates of depression we've ever known as a nation, highest rates of anxiety we've ever known as a nation. So anybody who's on this and doing work with kids on a daily basis, thank you all so much for your help, hard work. I know a lot of it's thankless. So thank you all.
Thank you so much, Dr. Chevalier and Colleen. Yeah, we could talk about this all day. I'm like picking up with the chat, and obviously I see like private practitioners, I see people from schools all over the place. And so I know working with adolescents is like Dr. Chevalier, sometimes, not that thankful, but
Yeah.
It's something that we're all passionate about, and I can tell obviously by the conversations. My number and my number is correct, but my email is incorrect, so I put it in the chat. But also, one of the questions was about our summer program. Yes, the goal of our summer program is to help obviously our adolescents when they're not in the school year, to kind of help, especially with those transitions as they transition from middle to high school, even like 7th to 8th. We We know, we work with these guys. It's difficult. Executive functioning is a huge part for a lot of our kids, especially as they move from middle school to high school. So yeah, that's all the goal for us to kind of work in our summer program to help them, support them as they transition through and navigate kind of this time in their lives. So feel free to reach out to Lori or myself. We are happy to help connect you. And again, obviously, Dr. Chevalier is our adolescent medical director. So he is the one that will be seeing or navigating some of these kids that come into program, if not all, right, Dr. Chevalier?
Well, I certainly review every case for every adolescent
Exactly.
who comes to our program. Absolutely.
Yeah. So again, thanks so much. I know we could be on all day, and it looks like so many of you guys have stayed on. So if there's any other questions, feel free to quickly kind of get them in. Otherwise, email Lori or myself, and we can obviously easily connect with Colleen and Dr. Chevalier and or navigate them ourselves. So thanks so much. Happy Friday, everyone. Enjoy the weekend.
Enjoy the weather.
Yeah.
Finally getting some nice weather out there.
Yeah.